So Gil, just looking at some of those trauma
Hey,
cases, you were saying you'll
so
actually
Sean, I was gonna.
good.
Oh, Sean, I was gonna ask Gil. Um, does that speak? Are you concerned about the bone graft encapsulating the nerve or the artery based on like you putting it in a lateral column defect, or I saw even on your tibia? Is that a concern, or does that speak to like the consistency of the bone graft being able to be placed where we want it?
Yeah, I know what you're asking. It's not a direct concern because I haven't seen any of the issues that, in the years past, we had seen clinical cases referred to us that had undergone BMP, bone grafting. And in some of those cases, we saw some pretty traumatic results. In other words, there were cases where a clavicle was bone grafted with a BMP and the patient had extensive amount of heterotopic ossification throughout the whole musculature into the neck. And it was a pretty dramatic case to where they really couldn't move their neck anymore. So it was an extensive debridement of that HO and, obviously a very complicated case in that area. And so I think that's what you're asking. I haven't seen that. And so, yeah, I'm always concerned about anything, but because I haven't seen it in the cases we've done, especially those and, compromised areas around arteries or nerves, that I haven't seen that fall out like has been reported in that what we've seen clinically with some other products, especially the BMPs.
Yeah, I agree, Gil. I haven't seen that either in some of the applications. I've used it in total knees, even with some uncontained defects in total knees. I haven't seen kind of the heterotopic ossification or like growth in an uncontrolled environment. And I think it may speak to the consistency and comfort level of the bone graft. When you kind of place it, it stays in kind of the geometric location you put it in.
So Gil, just going back to your technique there on the grafting, will you graft at time 0? I wasn't sure if I was understanding that right, or you'll go back at the 6-week mark and graft.
Yeah, for the most part, I have been doing the standard 6 to 8 weeks when they have a soft tissue defect. That's kind of our standard protocol. Now, I have had, I think, 1 or 2 cases now where I have done it acutely. So, I don't have long enough follow-up to say either way, but I would say what I've seen, at least in that time period, has been positive. And so I think that there's always things that can cause paradigm shifts, if you will. And so I think the standard protocol for at least a lot of my colleagues is when there's soft tissue injuries, defects that require reconstruction, and you have bony defects, typically they'll bring them back. There was those reports in the BMP studies that showed within 2 weeks you could do acute BMP use. Obviously some of those fallouts from those studies have transpired to where it's maybe not done as it was done like a decade ago. But my point is, I think as I do more cases acutely and in the right circumstance, that probably will be more positive than the negative, meaning that it might cause a paradigm shift to say, okay, let's just do acute bone grafting, even if they have a soft tissue defect. And so, yeah, I think it's a good question. And as more data is collected, at least from our end and is published, that might cause a shift.
So most of us are taught never say the word always or never, but I'll give you, my 2 cents as a sports guy. The most troubling fracture for me is a clavicle fracture in a smoker, and those seem to be the guys that break their clavicles. So are you bone grafting clavicles always, sometimes, never? What's sort of your algorithm there when you treat those?
Sure. Yeah, I would say seldomly, and a lot of times it's going to be when there's just extensive comminution. They have a lot of medical comorbidities, things of that sort. But yeah, especially as you mentioned, the smokers are always going to be a higher risk for renal disease. And so I haven't, but I know that certainly with some of those factors, especially a large area of comminution and severe comorbidities, those would probably be the subset that I have done bone grafting. I haven't used the NanoBone for that particular instance, only because I probably haven't had that particular case, and since I've been using it.
Hey Gil, I got a question for you. Were you using a lot of different bone grafting products before you got to NanoBone, or were you using one? And are you using just NanoBone now, or are you still using other stuff?
Sure. Yeah. I mean, I think 15 years ago with open fractures, at least, especially the tibia, was probably a lot of BMP. And then as their kind of things fell out after things were published showing maybe less favorable results, I was just always autograft, like just, probably 12 years ago, it was iliac crest. As some of the technologies came out with the reamer irrigator aspirator, then I probably used that for a good 8, 10 years. And so for especially my large defects, as I've been utilizing this more, I would say it's been a long time since I've used autograft. I would say a long time for me is probably 18 months or more, only because of the preliminary results I've seen. So I would expect that to keep trending. I think, we have a couple of cases this week actually that, with the large femoral defect, that once those are probably sterilized after about 6 weeks, we'll probably go to a NanoBone. Whereas in the past, I probably would have done just a reamer irrigator aspirator application of autologous bone graft.
I think I alluded to in one of my talks, one of the key things about this versus a calcium sulfate or chips is that you're inducing that ECM so quickly. And those other technologies don't do that. They basically create a conduct for you to go do that, and then it resets it all up, and then it has to build the ECM. So there's actually a period where we think we're like, oh, we want to see a little bit of callus, but that's actually could be some of the most highest, weakest point actually during that period of time of 3 weeks to 8 weeks when it's being resorbed and reestablished. Would you agree?
Yeah, I agree with that. Yeah, I think it's both the quickness to see that remodeling occur, but then the thoroughness of completion of bone formation.
So Gil and Scott and Nirav, if you're back with us, we keep hearing this theme that it seems to, show radiographically some healing quicker. Has that changed your weight bearing times at all? Are you weight bearing your osteotomies any quicker, Scott, or tibial plateaus, Gil? Is it changed it yet, or we're still trying to learn and see what we got before we go, diving into the cliff?
I've cut my weight bearing from 8 weeks to 6 weeks for my PAOs, and my DFOs have HTOs. Controlled, well-fixed osteotomies.
Gil, what about you for like tibial plateaus and fractures like that? Have you changed your weight bearing protocols?
Yeah, I mean, I'm probably still around the 6-month range. If anything, maybe earlier to 4 weeks, but I wouldn't say that anything earlier than that.
I'm sorry, you said 6 months non-weight bearing?
Oh, no. I would say still around the 6-week mark, maybe,
Okay.
But I haven't gone earlier than that, like 2 weeks or something like that, because I think it does take time.
Gotcha. Fair enough. Nirav, you with us?
I am, Sean.
Yeah. So again, in a sports practice, I'm not sure if you're addressing Jones fractures or if your foot and ankle guys are, but I know, one of the most challenging fractures for us are those Jones fractures. And, I was talking to our foot and ankle guy just about the idea of bone grafting, some of those fractures when they put the screw in. Anything you've had experience with or your guys have, or maybe not so much?
So Sean, I actually have, ironically, I have not used it in a Jones fracture. But one thing that did come up is, interesting enough, our surgery center liked the bone graft because it's a synthetic component, not having to have that discussion from a donor for the patient, right? So a lot of the bone grafts may have some allograft component and so forth. So that's the one big push, and the storage is the other portion that our surgery center likes too. So those are the two key components. And from a cost perspective, the not needing some kind of adjunct in order to kind of, like Scott and Gil were referring to, kind of the EMC and the kind of the breakdown of the nanocrystallite and the AGS. I think that's really critical because you don't need to have some adjunct biology to kickstart it. So I think those things make even the Jones fracture, to me, would be a great indication if you potentially are concerned about your fixation and not getting compression around that metaphyseal diaphyseal junction.
Yeah. Any abstract considerations, subchondral cystic formation in rotator cuffs or insufficiency fractures, any place that you're looking at this, Nirav, and saying, you know what, this is going to give me, an advantage versus what I'm typically doing now?
Yeah, so I think in the insufficiency, an opportunity. The reason is, right, most of the systems currently on the market take a time to set or so forth. A rotator cuff cyst, I'm not sure it would be the ideal, just because it structurally doesn't set to a firm setting when you pull out back on your anchor, so it wouldn't give you that robust fixation if you're if you're putting it into a cyst type lesion, because it does take a period of time. anywhere from 2 to 6 weeks to get that concrete solid bone formation versus the other, there are other products on the market that will give you some kind of calcium phosphate sulfate derivative with some kind of adjunct, almost I want to say cement type material that you can pull out off on your anchors. So I've used it on certain scenarios, but I think insufficiency fracture may be a really nice component because unlike the other products, this may actually decrease the stress rises and the fractures in that adjacent cancellous bones.
Gotcha. Thanks, Narav. Gil, fracture considerations on your end, when you're deciding, you're going to graft something, you're not going to graft it, what are some of the things that you're looking at that 6-week mark? Are you looking at radiographic healing? Are you looking at the patient and their ability to heal because of protoplasm or otherwise? What is your algorithm for grafting in general?
Sure. Yeah. So, I think all of those. And so the key factors are all our patients, upper or lower extremities will get these disability score evaluations. And so we evaluate those, but I think it comes down to kind of just the medical history and asking how they're doing clinically, how they're functioning, and then seeing obviously what, if it's around a joint, what their range of motion is, what their strength return is. I think when you have some defects that you prior to this and on bone grafting, usually I wouldn't necessarily see the correlation of the clinical and radiographic findings, meaning maybe x-ray showed some healing, but not a lot. And then clinically, they were just still in a lot of pain. They just didn't feel comfortable. Here I'm seeing the opposite, where you see more healing on x-ray, but also clinically patients are, really wanting to get back to either full sport or full work or activities because they're in that 6-week time period and radiographically and clinically they're feeling better. And so in all those aspects, those are things I consider. Now, when I look at maybe fractures I've treated and maybe they're in that kind of 6-week to 12-week time period and they're not healing, typically I'll look at what is the area of bone healing. Do they have areas that maybe have healed and others that don't appear to be healed? Whether it's a distal femur, I think in trauma is probably one of the ones that are more notorious for acute fixation with subsequent need of bone grafting at 6 to 8 weeks or even 12 weeks if they're not showing healing. And so I'll look at everything radiographically, clinically, occasionally if needed. If I'm still suspicious, I might get a CAT scan just to maybe look a little deeper and see what kind of healing they have. How robust is it? Or there are zones that just don't have any bridging bone that may need a follow-up bone graft. And so kind of all those variables, what I look at.
Gotcha. So we have a question coming in from the audience right now asking, do we have any experience with OCD lesions? This would be more for Narav and Scott, most likely. Guys, any experience dealing with OCD lesions using bone grafting?
Yeah, we've tried. I tried in the lab to do some testing, and I thought, maybe it'd be a great way to do it. I don't know if it's quite there yet. I don't know if the fixation is as good as we would hope of the cartilage.
Narav, anything on your end?
No, so, Sean, the only thing I can theoretically think about is, when we have an Oates plug and the autograft looks pretty good, but you always have kind of that edema around the cancellous portion of the graft. I think there may be a window or an opportunity potentially with a coat this to incorporate the process of the cancellous Oates plug with the NanoBone. The only thing that I'd say is Brian Cole's done some nice work, right, where he's talked about irrigating the Oates plug, if you're using a cartilage plug, with either a pulse lavage or soaking it in some kind of biologic. So I don't know, from a cost perspective, if it would make sense, it potentially could make sense to kickstart that incorporation with the NanoBone technology. But I'll be honest, I have not gone down that path yet. Scott or Sean, your opinions on that?